For falling room. You're walking into your patient's room. This is Mr. Smith. He's 79 years old. He comes in after a syncopal episode with multiple falls at home. He has a history of orthostatic hypotension. He takes Coumadin for his AFib, and he also has a history of Alzheimer's. All morning for you, he's been complaining that he's lightheaded, but every time he needs to go to the bathroom, he insists that he uses the actual toilet. He doesn't want to use a urinal, a bedpan, a bedside commode. Don't read anything in the blue.
Okay.
So now you're going in to assess your patient.
Hey, Mr. Smith.
And I want you to notify me of anything that you see in the room that could pose the patient a risk for falling.
Well, I could fall on the
Yeah.
oxygen tubing
Very
in
good.
addition to when we get Mr. Smith up.
There's a lot of cords over here, and I don't know if we need this equipment or not.
What is that equipment?
Is this the video monitor?
Uh-huh.
Why is it on the chair and disconnected?
Very good.
Oh,
I wonder why.
Okay.
This
Yeah.
room actually
Should
doesn't
he
have
be
the
on?
capability.
Oh, and you should be on
Yeah.
video
Right.
monitor.
On his board, it looks like that's one of his plan of care and goals for today.
Okay. And he does have Alzheimer's, so
He does.
confused.
He does.
Okay.
Yeah.
All right. So we'll have to call someone about that, Chris.
I'm seeing an unconnected cord here.
That's
We'll see what this
accidental, but very
goes
good.
to.
Excellent.
And I thought it might go to the call bell, but it looks like Mr. Smith's call bell is
Disconnect.
across the room over there.
Not helpful.
That doesn't help if you need
Oh,
to
right,
go to the
okay.
bathroom.
Yeah.
Aileen, you touched on a very good
Yeah, so blood pressure. I know that you were discussing orthostatic hypertension, right? But
Mhm.
this isn't connected to anything, or are we supposed to take one?
No.
Are we? No.
What's
but
wrong
it's-
with the device, or what you're holding in your hand?
Does it not
We'll
work?
talk about
No,
the cup.
Or is
Yeah,
it the,
we're
or is
thinking
it the
size, right?
because
So
it's
this is a large cuff, but not really appropriate in size for Mr. Smith's arm.
Okay.
So just something to consider when we're doing our blood pressures,
Yep.
making sure that we're selecting the right size cuff.
Doesn't look like a large adult.
And then,
Okay.
So this is.
How about bed alarms? Are they on?
oh,
Oh.
Please check.
Zone 1. What? Never.
never.
Correct.
Never.
Which zone do we want?
Zone 2, always.
Very good.
Oh, let me set that for you.
Thank you.
Okay.
Perfect.
Thank you.
Okay.
And then Mr. Smith is getting very wiggly in the bed because he really has to go to the bathroom. And he's insisting that he needs to get up. And he says, I feel like I'm wet.
Okay.
He's wet. Let's check him.
Oh my gosh.
Oh, boy.
Oh no.
Yikes. I think we should call for help, Chris.
Yeah. Press the button.
There we go. That's it. Oh, is it not on? No, I want to pull that out, right? Okay. There we go.
We'll get some
You can
assistance.
cancel it.
We'll get some.
Got it.
Yeah.
So what is
So we're not
this?
getting him up, right?
Yikes. No.
No.
Looks like someone may be bleeding. Uh-oh.
Correct.
Yeah. Oh, look at that. Oh, is that a, what is that?
It's
Oh,
it's
that's
part of
just,
it.
yeah, that's just
Okay.
part of Mr. Smith.
Oh, part of it. Okay. All right.
Mrs.
Make
Smith
sure I
really,
wasn't.
but
Okay.
So you've
All right.
identified correctly that we are not getting this patient up out of bed.
No?
No.
We want to make sure any patients that come in with any sort of bleeding, whether it be nosebleed, vaginal bleed, GI bleed, which we've seen throughout our falls for the year,
Yep.
they pose a risk to fall, whether they're young, in their 20s, 30s, or up to 100.
Yep.
Doesn't matter how old you are, if you're bleeding, you can fall. Another thing that we wanted to hit home was orthostatic blood pressure measurements, which sometimes are not being done, which is very important, especially if the patient has a history of orthostatic hypotension.
Yeah.
And now, say we're stable, the doctor comes, clears the patient, says, okay, you guys can get him up to the bathroom if you need to.
Mm-hmm.
He got whatever procedure he needed to get done, and you and Chris are coming over to the bathroom.
Okay.
And you're assisting Mr. Smith to the bathroom, and as he's sitting down on the toilet, he pulls the door closed and says, "You need to stay on the outside of the door."
Oh no, Mr. Smith.
Yeah,
We can't leave you alone for your safety.
you have to be within an arm's reach.
Yep. It's our clinical practice guidelines that we follow. We stay with everybody and we'll make sure that you get to and from the bathroom safely.
And he's insistent that you do not come in, and you are still stuck on here, and he's holding the door, and then he goes, "Oh my gosh, I don't feel good," and falls. What do you do now?
Gonna make sure he's okay, but Chris will call a fall alert.
Very good. Very good.
We'll
And
get a
how-
fall alert call.
Perfect. And how do you do that?
Well, I dial 1212.
Yep.
Perfect.
Mhm.
And what would you say to the operator?
We have a fall alert on the 6
East.
Perfect.
Yep.
Mhm.
Very good.
Room, whatever, wherever
Very
we are.
good.
Yep.
You guys hit all the major points.
Yeah, you
All
skipped.
right.
Very good job. The
Yeah.
only
All
thing.
right.
Labsy room. We're going to talk about CAUTI's first. We updated our bladder scan protocol order. Now you can go up to 400 milliliters when you're bladder scanning, and you could bladder scan every 4 to 6 hours. And you could do it 4, 6, 7 times a day, whatever the patient needs, for up to 48 hours. And then we're going to request another order for bladder scanning if the patient still needs it after 48 hours. We're not going to be inserting that fully. When we're utilizing the bladder scanner, we have the protocol on the actual bladder scanner. We have the proper disinfection wipes to clean the bladder scanner, and we want to make sure we clean the head really good. And we want to make sure we're using the larger gel, not the smaller gel. The smaller gel, you'll need 3 packets, and it's not as reliable, the results, if you don't use a good volume of gel. When we're talking about Foleys, if your patient has to have a Foley, we want to make sure that it's always at the lower than the bladder level. When the patient gets transferred, we don't want to throw it up on the bed. We want to still keep it down below. The patient should have a stat lap in place holding the catheter down. This one's taped, not a good idea, and we're going to rip the skin off afterwards. If we have to draw any urine specimens, we're going to use the port over here. We're never going to use the bag in order to draw any kind of cultures or urinalysis. When we're drawing that, we're going to scrub the hub really good before we put on our syringe and take our sample out. Also, after any time we do perinatal care, we're going to be doing Foley care, 5 wipes for 5 swipes. We do have the Provon here, but if you don't have this because of supply chain issues, you could still use the bed in the bath and just use it just like we do this, 5 wipes, 5 swipes. What else in regards to Foley care? Oh, alternatives. We have our female urinals, we have our male urinals. We also have bedpans. If you're using the bedpans, use the bags for the toppers, so it has an absorbable sheet in there, so when the patient uses it, it actually solidifies the urine. There's no spillage, and when you're done, you just zip it up and you could throw it away in disposable regular waste, as long as there's not a fistful of blood or more in the container.
Do you know where I can find that bag?
Those are by all the commode buckets.
Got it.
Yes. They should be in every supply room that has commode buckets.
Got it.
Now we're going to switch over to Clabsies. This patient has a central line. We're going to make sure that we're utilizing the chlorhexidine central line dressing kit. If the patient has a chlorhexidine allergy, we're going to use a plain one, and they're both available in the clean supply rooms. We want to make sure the ports that are covered with either an orange or the green or whichever cover we have available. They are alcohol impregnated most of the time. However, when we take these off, we're going to change them out every single time to a new one, and we're going to use Prevantix, the CHG, to scrub the hub, and we're going to scrub for 5 seconds. If we had to use alcohol, it's 20 seconds. That's why we always want to use the Prevantix. It has CHG, it's 5 seconds, it's faster for you. Also, patients are going to have chlorhexidine baths ordered, and we're going to have to do it at least once a day. We're decolonizing the patient and decreasing the bacterial load. preventing the patient to get that bacteria in their bloodstream. If you have to do blood cultures, we want to make sure we're doing 8 to 10 milliliters. Very important, because if we do 8 to 10 milliliters, we can get the results back of the actual organism within 24 hours, and then we can de-escalate antibiotics appropriately, and so the patients actually get better quicker because we're treating the right organisms. We're not going to get them any resistant bugs or C. diff because they're in on broad spectrum antibiotics. When you're drawing your blood cultures, you want to make sure you're using alcohol to decontaminate the tops, but you're going to use the chlorhexidine for the patient's skin. You're always going to draw them peripherally. That's the best thing. And you want to do it 15 minutes apart on alternate arms, or you could use the same arm, but make sure you space it out 15 minutes. Your IV lines are really important. Try and keep the system intact as much as you can. Make sure you're dating and changing your IV lines and your medication bags on a regular basis, and try to keep the lines closed. Each time we open up the ports, there's an increased risk of contaminating the site and therefore leading to a eclampsia. And I think that's it for today.
Thank you.
Welcome to the Quality Regulatory Room. I'm Megan, and we're going to go through with Karen here all the things that a surveyor might find as being a problem. Karen, I can't believe we took over this room. What were we thinking?
This is abominable.
Oh my goodness.
Oh my goodness.
Where's the Purell? How did they even get that off?
It's terrible.
Yeah.
Oh my gosh.
Wow. Sharps. Wow.
Oh my goodness.
It's no good.
My sharps container's
The
missing.
floor is a mess.
and broken. Look at the floor. We gotta call. Oh my. Are these clean? Are these dirty? I don't even know.
I have no idea.
I'm gonna go with dirty.
Yeah, they're dirty.
Okay.
Yeah.
Got a lot of cords
Oh
here.
my gosh, they left stickers.
A sticker of the.
Oh.
my god.
Not good.
Oh.
Not good.
Well, this might be a problem.
That needs to be fixed.
Yeah. I remember there's a phone number to call. Oh my god, the oxygen's standing up. Holy moly.
There's linens in there.
You think they're clean or dirty? What are you thinking, Karen?
They're dirty in my eyes. I have no
Yeah.
idea.
Oh, look at this beautiful decoration.
Hanging from the fire sprinkler.
Oh my goodness.
Yeah.
Not good.
Oh, I do this in my house, right? I just plug in one extension cord and another extension cord. I don't tell anybody about it.
No. Great idea. It's a great way to
Ooh.
bring your house down.
Oh, Karen, you mentioned this.
It's a rip mattress.
We probably should use duct tape, right?
Duct tape would have been better. I think
Yeah,
it's
yeah.
plastic flower.
No. You think that's what we do here in the hospital?
No.
No, definitely not.
Guys, take a look at this one. Frayed.
Oh, you know what? It's also due for inspection, like last year. So that's it's space heater. It's
I don't think we
summertime.
can have those.
No, I don't think so either.
Oh, not good.
No, not good. And this
Gotta
isn't good.
remove those.
Oh, that's broken.
And there's equipment here. The patient could get it. And there's an old coffee. Who knows when it's been there since. And the time is wrong.
There's a lot of
All needs a
hazards
battery.
here.
Look at all these wires. I don't know, Katie. We better call for help.
Absolutely.
I am. You are completely in the corner. You have no safe egress. And it would be extremely difficult for security or someone to respond and to help you. If you were the patient, we're here. We're stuck here. Also, what's in the room and what might not need to be in the room. A lot of the time you will see me, everyone laughs at me, I'm always rearranging the furniture when I show up in a code gray. But does this really need to be here? Can that chair go out in the hallway? Can this be rolled back? How can we get whoever is trained in CPI in the room safely and in the positions they need to be without all of the extra in the room? And of course, what could the patient use to hurt themselves or, God forbid, to hurt you? So environmentally, TV should go off. If you're trying to talk to a patient, de-escalate a patient, and the TV is blasting, not helpful. The environment, just those things alone, maybe we're at a 10, let's bring it to an 8. And then we start to work from there. Also environmentally, how many people show up to the code? I think think by instinct, we always think more is better, but it's not, patient. If I'm talking to you, I'm trying to listen to you, and there's a ton of chatter and noise in the hallway. Also, you don't really need a lot of equipment for a code gray, so your other nurses can go about and take care of the other patients. Somebody in the hallway to keep everybody else safe and direct them away from the room is someone that could be helpful. But really, that's about it. If we're talking, you're de-escalating me, maybe we're making some progress, and then I hear out in the hallway, you're talking about restraints or maybe some IM medication, or we called for more security to come up here. I'm gonna start to rethink all the work you just did by de-escalating me. I might actually re-escalate, because you told me you're gonna come back in 15 minutes. You told me I can take a PO medication and call my wife. And now I'm hearing at the corner of my, ear, this whole other situation that's not happening. You're also the person, you're putting that coworker, that point person de-escalating, the biggest risk for violence at that point. If we're talking about all these other alternatives and the patient hears me. Now you and I are in here, maybe a couple of people left the room, now we're 1 versus 1. Really scary. So to be mindful of where we're talking, the volume that we're talking. Also, how you're standing, how you're presenting yourself to the patient. If the patient is delirious, demented, or psychotic, hands in the pocket look like I'm hiding something from you. Hands behind my back. How do I know you don't have medication in the needle behind what's in your hands? And also a very challenging one-on-one body positioning is not going to de-escalate. Looking relaxed, having your hands visible, again in this sort of like safe supportive stance, should you need to pivot and leave the room, that's gonna get you a lot further with a patient. And then the volume of your voice. You should not be matching the response of the patient. You need to completely go almost in like the opposite direction. If they're yelling, and tell them, Sam, you're yelling. I can't talk to you like this. I would love to help you.
But they tell you to stop talking.
Right.
As you're saying that.
It's a lot easier. Something to say to the patient is, I'm gonna listen to you, and then when you're done, it's gonna be my turn to talk so that we can move forward. You can set that type of limit with the patient. But yelling back at them is only, you're never, the situation's just gonna stay the same.
Yeah.
You're never gonna de-escalate the patient. Yeah. And anybody can de-escalate a patient. I think we always forget this. Maybe it's a security guard who they knew from another time that they've had a hospital visit. It's Sam who they had the last time they were post-cath, and they know her even though she's not the nurse. Whoever has the momentum should continue with the momentum. Just because security shows up, just because 3 North Behavioral Health team shows up, if somebody's really got a good in with the patient, we should work with it. Yes, eventually they might want to talk to the psychiatrist, or they might want to talk to a security guard. But if someone has momentum, it's not productive to come in and interrupt them. It would not be helpful for me to say, okay, well now I'm here, so I'm from 3 North, so.
Right.
It's disruptive. Anybody can de-escalate a patient. They might remember you from another hospital stay. You don't know. I'm sure patients remember you.
Or you're just not the one that's been yelling at me all
Oh,
morning.
Right. Well,
You haven't
you're
told
a
me what
brand
to
new
do all
person.
morning.
Well, that's
Absolutely.
These people haven't let me.
Yes.
Well, that's it.
Absolutely.
The primary
Some-
nurse might not be the
Right.
person.
Sometimes patients
Tell me
think
what's
security is
tell me what's
police
happening.
and they
Right.
like that.
Mhm.
Go for it.
Yeah.
Go for
Yeah.
it.
You want the police?
Right.
I'll get you the police.
Absolutely. And then if we're dealing with some patients who are delirious or demented, arguing, and even psychotic, arguing with some of their delusions is not always the most productive thing to do. If you are a former nurse and think that you have work in the morning, why would I counter that?
Why? I'll have
Why?
a nonsensical conversation with anybody.
Absolutely. Absolutely. If it's nighttime and you're telling me I have to go to work, I have my shift, isn't it a little bit more productive to say, Sam, it's 8 o'clock at night. Your shift is in the morning. You should get some rest right now. Where do you work? What's the productivity of, I'm a nurse? No, you're not. I'm a nurse. No, you're not.
Right.
What would you be accomplishing? So, a little white lie could really go a long way in de-escalating a situation. And maybe finding something for them to do with their hands, with that energy, is really, really helpful. Could they, we have patients on 3 North do this, like make us packets with papers. That's not harmful. They can't hurt themselves with paper. We use these packets for group.
Yeah.
Put one of these, and one of this.
Perfect.
Right. Do that together, make me 10 of them. So burning that energy, that with something that's not
I'll
harmful.
go through every washcloth that we
All
have.
the laundry. I'm
Folding. Can you put one purple
Can you
tube in
please?
all of these bags?
Yeah.
You would be so helpful. We need it for shift tomorrow. Great. I think a lot of people are familiar with the patient who was here on the 6th floor. He was a former accountant. He had a desk with a calculator, some paper.
I need some financial
Crunch your numbers. Go for it. The arguing
Rejoining your call on hold. That was clever.
is not gonna. It's not gonna get you anywhere. So the white lie, is helpful. It's my job on 3 North to challenge somebody's reality and delusions after a couple of days of their antipsychotics. Not really, not really in a code gray when they've just arrived to the emergency room, or not the 88-year-old gentleman who is delirious right now. Not productive.
Yeah.
So, do you have any questions?
No, this is really great.
Yeah.
Welcome to our sepsis room. So this lovely poster here has our different sepsis guidelines. So you can take a moment to pause the video and look at the guidelines for the different departments. So this is the ED, inpatient, MCH, and PEDS. So take a moment to pause and look a little bit closer at these different guidelines. You can also find them on Policy Tech as well as your code cards. These are some helpful sepsis reminders. Also, if you take a look at this card over here, this will be placed on all of the vital sign cards to remind you of the different sepsis criteria. If you turn it over, it also has a QR code that has our sepsis guidelines on it. Then we have this activity here. I see some lactated ringers, a lactic tube, Zosyn antibiotic, blood cultures. This activity is really to put us in the different order that we would do the different interventions, making sure that we get our blood cultures before giving our antibiotic. Please be mindful that in this case, lactated ringers is not compatible with Zosyn.
This is our pressure injury prevention room. So a hospital-acquired pressure injury is any pressure injury that's identified after the 24 hours that a patient has been admitted to the hospital. We should be doing skin assessments on admission, on transfer, each shift, and if there's a change in status. If you receive a patient back from the OR or from IR, we should be doing skin assessments as well. Our pressure injury prevention bundle includes making sure that the patient is on the appropriate mattress. So orange and blue mattress is level 2. When we add a bed pump to it, it makes it a level 3. What that does is puts continuous air through the mattress and helps to redistribute the weight under high pressure points, and also helps with the microclimate of the skin. So if you have a patient who is incontinent has a bad yeast infection, who is diaphoretic, or who is morbidly obese, holding moisture to the skin, it's going to help to control the microclimate for that patient. The Prevalon system is our anti-friction shear sheet, so it helps us to reduce the friction when we boost the patient. Also helps to reduce the shear force when we sit the patient up in bed. The Prevalon system will take the blunt of that shear force versus the patient's. Our chair cushions or static air cushion should be used on all high-risk patients when sitting in the chair. You can also use that for patients who are morbidly obese, who you can't get their feet into heel lift boots. For absorbent pads, every additional absorbent pad increases the risk of pressure by 22%. Each pad can absorb 1 liter of fluid, so it holds more than a Depends could. So we should only be using 1 pad. If we line the bed with too many pads, it's going to reduce the effectiveness of the level 3 bed pump that we added. We should not be using Depends or briefs in bed or in the chair. They should only be used to walk with the patient by physical therapy, and then once they get back to bed or the chair, we should remove them because it does hold moisture to the skin and increases the risk of pressure injuries. Bed pans, we should be making sure that the patient is only on the pan for a limited period of time. We've had patients end up with extensive wounds from being left on the bed pans for periods of time. Medical devices is going to be our big push this year with reducing. A huge takeaway is pulse ox probes. If we do not need to be using them, we should remove them if they're not connected to the monitor. We had a patient that had a pulse ox on the foot with the heel lift boot in place, was not connected to the monitor, and the blue portion coiled up to the side of the foot, and they ended up with an extensive deep tissue pressure injury that was hospital acquired. So if you have a patient that needs to be on a continuous pulse ox, we should be reassessing the patient that it's still appropriate for them to be on it and rotating these sites every shift. We should also make sure that we are not putting it on the feet. And if we have to put it on the feet, we should not be using heel lift boots or socks because it increases the risk of pressure in that patient. We should also make sure that we are watching for any bed trash after we turn and position the patient, that we are not leaving anything underneath the patient, that's needle caps, bed wipes, or any sort of tubing or devices that increases the risk of pressure on these patients as well. All of our medical devices should be rotated every 4 hours. We switched to the hybrid BiPAP mask. It does sit below the nose, and it has an area for the NG tube that if you need to use an NG tube with the BiPAP, it should sit in that area. We should still offload the device every 4 hours. With our high flow, we should be using Mepilex on the ears and the cheekbones. Again, repositioning the device every 4 hours. NG tubes, we should be using a stat lock. We should not be using tape. That is poor practice. Another takeaway is pigmentation. People with darker skin tones are going to be at higher risk of developing stage 3 and stage 4 pressure injuries because you're going to miss the warning signs that you would see in someone with a fairer pigmentation. People with darker pigmentation are not going to have your typical blanchable erythema. They may have hyperpigmentation or a bluer hue to the skin. So it's so important that we're turning the lights on. We're looking at the tissue to the adjacent area, palpating. Is it warmer? Is it cooler? Is it painful to touch? Those are often warning signs for pressure injury development.